Hello, this is Kim McAllister, and now we're moving on to Chapter 37, where we talk about respiratory drugs. Our objectives for this lesson are to discuss actions, indications, contraindications, cautions, drug interactions, adverse effects, dosages, and route of administration for bronchodilators, corticosteroids, leukotriene inhibitors, anticholinergics, and xanthine derivatives. We're going to discuss use for phosphodiesterase spore inhibitors and Xolair. Develop a nursing care plan and teaching plan for patients using bronchodilators, corticosteroids, leukotriene inhibitors, anticholinergics, and xanthine derivatives to control respiratory disorders. Doesn't this sound exciting? So we're going to start off for speaking just a moment about the diseases of the lower respiratory tract. Patients often have either chronic obstructive pulmonary disease, asthma, or emphysema. These conditions are chronic, and we will discuss these in depth next semester when you take chronic nursing care. For now, the main thing to understand about these conditions is they cause bronchospasms and wheezing and other problems. Status asthmaticus is in a medical emergency. This is an asthma attack that doesn't resolve. And so this is a medical emergency, and you would need to act rapidly and respond correctly in order to rescue your patient. Chronic bronchitis is usually caused by chronic exposure to irritants, and emphysema is caused by destruction of alveolar walls. What I want you to remember now about these conditions is that all of them obstruct airflow, and so they are different diseases and have a different mechanism of how they cause problems and different origins, but all of them result in obstructed airflow, and so they can have a dangerous and even deadly effect on the respiratory tract. So we're going to discuss the drugs that are used to deal with these issues and other issues of the respiratory tract. I want you to I put the information in this slide for you about those diseases because you will be taking care of patients with those conditions this semester, and I wanted you to have that as a frame of reference. So bronchodilators are given to patients to relax the bronchial smooth muscle, and that helps to open up the airways. It dilates the bronchi and the bronchioles, and it helps to restore the airway and airflow. So there are three classes of bronchodilators that we'll be discussing. And right now in part one, we're going to be talking about the beta adrenergic agonists. These are medications that are used in the acute phase of asthma attacks. So when we were talking about antihistamines and decongestants, we referred to at times that we would not give some of those medications to people with asthma. And that's because we want to be able to give these medications, the beta adrenergic agonist, at a time of an acute asthma attack. These will quickly reduce airway obstruction by stimulating and dilating the bronchioles and will restore normal airflow. There are three different types. We have non-selectives and selective beta adrenergics. The non-selectives stimulate the alpha and the beta, which are the receptors for the cardiac stimulation, and then the beta 2, which is the respiratory receptors. Epinephrine is a non-selective adrenergic, and so it will stimulate both the heart and the respiratory receptors. The non-selective beta adrenergics stimulate both beta 1 and beta 2 receptors, and an example of that is metoprolol, and that's also known as Albuterol. Do not confuse that with Atrovent. Atrovent is an anticholinergic. Albuterol is a beta-adrenergic agonist. There are also selective beta-2 drugs as our third type, which only stimulate beta-2. That's the respiratory, and that would be albuterol. Albuterol is usually what is in a patient's rescue inhaler. So these act by stimulating the specific receptor, either the beta or the beta-1 or the beta-2 or both. And it ends with dilation of the airway. And this is very rapid, and it relaxes the muscles in the airway and causes the dilation of the bronchioles. So because it relaxes the muscle and dilates the bronchi, it will stop the bronchospasm that can happen with pulmonary diseases. And so they're used for treatment of acute asthma attacks, and they're also used for hypotension and shock because these medications act very rapidly and have a very strong effect. So contraindications for these would be any known drug allergy to them. Patients that have uncontrolled hypertension would be in trouble if we gave them these medications because it will make their blood pressure continue to rise. They can also cause cardiac dysrhythmias, so they are used very cautiously or not at all in patients with arrhythmias. They also cause a high risk of stroke because in addition to opening up and dilating the bronchioles, unfortunately, they constrict the blood vessels. So the adverse effects for alpha and beta, drugs that stimulate both alpha and beta, such as epinephrine, would be insomnia and restlessness, anorexia, vascular headache, hyperglycemia, tremor, and cardiac stimulation. Anything that stimulates the nervous system. So beta-1 and beta-2, this is your Albuterol, metoprolol. This is going to cause cardiac stimulation because it's stimulating both beta-1 and beta-2. Remember, beta-1 is cardiac and beta-2 is respiratory. It can cause tremor, anginal pain, vascular headache, and hypotension. The beta-2 albuterol can cause hypotension or hypertension, vascular headache, and tremor. If a patient takes initially, albuterol will not stimulate the heart, but if they take too much of it or too much too often, it can then begin to stimulate the heart as well. So when non-selective beta blockers are used, and we discussed beta blockers when we talked about dysrhythmia medications, heart failure medications, and hypertension medications. When patients take beta blockers, it will reduce the effect of the beta-adrenergic agonist. So patients with asthma and other respiratory disease should not take beta blockers. Patients that are taking MOI inhibitors need to be, it's a contraindication with those. They would have to discuss that with their physician and decide whether or not that should be taken. Generally, they're avoided. They don't work well together. Sympathomimetics, again, that's additional stimulation on top of the stimulation from the beta-adrenergic agonist. And so the combined effect of that would have to be evaluated. Patients who have diabetes and take beta-adrenergic agonist can have an increase in their blood sugar and their blood glucose, and so they need to monitor their blood glucose very carefully. Your short-acting beta agonist the short-acting beta agonist inhalers, also referred to as SABA, would be albuterol and levalbuterol, which would be Ventolin or ProAir for the albuterol, Xopenex for the levalbuterol. The long-acting inhalers would be like Brovana or Saravent. Long-acting inhalers are not to be used during an acute asthma attack. When a patient needs a rescue inhaler, they need to use the short-acting inhaler. The long-acting inhaler will not provide a rapid response to assist when the patient needs the rescue inhaler. And it's very important that you teach them that. So albuterol is a short-acting beta-2 specific bronchodilating beta agonist, as we've discussed. It's the most commonly used drug in this class. So one thing that I recommend is that if patients are using these inhalers, have them pull them out and show them to you, and check the expiration date and look at the meter on the back and see if it's at 0. Sometimes patients don't understand that the medication can run out. So this is something to think about with your teaching. They should not be used too frequently. They should have an asthma action plan. If they don't, they need to discuss that with their provider, or you need to contact the provider and let them know the patient is not aware of their asthma action plan, and that asthma action plan should detail when they should take it. Also, if patients are using it for chronic bronchitis or emphysema, they too should have a plan for when they have exacerbations. Albuterol is for oral and inhalational use. The inhalational forms are the metered dose inhaler, and it can also be used in a nebulizer. Saravent is one of the long-acting beta-2 agonist bronchodilators, never to be used for acute treatment, as I said before. This is a maintenance medication, and patients should never take these more than twice a daily. And next we will move on to our next class of drugs.